Thank you for tuning in to this lecture on hypertension and its effects on the heart. Here is my disclosure slide. So we'll start this talk by briefly reviewing the pervasive problem of hypertension at the population level. We'll then discuss the effects of elevated blood pressure on cardiac structure. We'll also discuss the effects of elevated blood pressure on cardiac function. And we'll also touch on areas for future research in this field, which is really an ongoing, active scientific endeavor. We'll also summarize key points at the end of the lecture and include at least one case study that's relevant regarding some of the points raised. So as many of you already know very well, hypertension is a very widely prevalent problem affecting half of the population over age 50, 2/3 of the population over age 65, and 3/4 of the population over age 75. What's more, unfortunately, it's still the case today, unfortunately, not all patients with hypertension are even aware that they have elevated blood pressure. And among those who are aware, not all of them are receiving treatment. And even among those who are receiving treatment, only a fraction have their blood pressure under what we would consider to be adequate control. And these are actually old data using the older thresholds and targets. So if we were to do the same analysis using newer data, these values would be even more concerning. And what this means is that the effects of hypertension on target angle organ damage, including on all the major organs, but particularly our topic here, the heart, these effects will continue to persist. They'll continue to persist as we recognize that hypertension continues to be pervasive, relatively still under-recognized, relatively still underdiagnosed, relatively still undertreated, especially when we use and apply the newest guidelines. We know that blood pressure increases steadily with age. This is part of the reason why the prevalence is so high. The population continues to age. And this increase with age is really marked by distinct patterns. There's variation across the population, but they're really sort of average patterns that we've recognized over time through epidemiologic studies like this one. The patterns include progressive rise in systolic blood pressure, a rise and then midlife fall in diastolic blood pressure, correlative increase in pulse pressure, a marker of arterial stiffness that especially accelerates with its increase in older age, and a steady then persistent elevation in mean arterial pressure. All of these different metrics have been shown to have pretty profound effects when it comes to even subclinical cardiac change. Importantly also, the life course elevations in all of the blood pressure components that I just showed you have been associated with, in population studies, with all of the major cardiovascular endpoints. And in particular, pulse pressure has been especially strongly associated with increasing risk for heart failure as well as all-cause mortality. The biological mediators underlying these relationships between elevated blood pressure, all of its components, and all the different cardiovascular outcomes, subclinical as well as clinical, are likely multifold, very complex in terms of their interactions. At the same time, fortunately for us, they also likely manifest as subclinical as well as preclinical abnormalities that we can actually capture if we're attentive enough and we're focused enough using a variety of different cardiac imaging techniques. And this is because, of course, the heart and the circulatory system, not just the arterial, but also the venous circulatory system, really exist in a closed system, in a closed loop system. And we knew this because we learned it in the first year of medical school. And this closed system is one whereby changes in both cardiac and arterial structure and function in particular occur in parallel. It's not to say there isn't this similar connection on the venous side, but in particular, it's very strong on the arterial side. And so the prototypical relationship between hypertension and heart disease was really reported now decades ago, for the first time, very clearly from the seminal Frame Heart Study article published in the New England Journal in 1990, showing that increased LV mass is related to both incidence of cardiovascular disease as well as all-cause mortality. Fast forward now, here are more recent data from the atherosclerosis risk and community study, multi-site, epidemiologic, large cohort, biracial population cohort study. And in this study, the investigators showed consistent relationships between cumulative life course blood pressure elevation with cardiac and structural and functional changes actually involving both the right and the left side of the heart, but particularly the left side of the heart, and in turn, risk for heart failure in particular. And so what they did here is they looked at cumulative blood pressure measures, not only cumulative measured, but also what they call underlying, taking into account whether or not individuals were taking blood pressure lowering therapy at the time their blood pressure was measured. Understanding or assuming that really the natural or the sort of the native blood pressure elevation would have actually been higher were those individuals not on blood pressure lowering medications at that time. And so to understand in more detail, more effectively, the pathway from hypertension to a given cardiac disease outcomes, an area still of intense research, we have a framework for trying to put this in context. So to try to understand the pathway and the interval development of subclinical cardiac disease, it's helpful to think about the progression along a spectrum that involves, of course, changes at the most basic ground level, the cellular level, changes at the tissue and organ level, and changes that go on from these more basic levels to manifest as a clinical syndrome such as heart failure. And all these changes, it turns out, we can actually measure. So in the basic science or translational science labs, we can actually look at myocyte changes, myocyte hypertrophy, measure myocyte dropout. We can look at interstitial changes, can measure relative quantities or quality of interstitial collagen fiber deposition, the relative pattern of foci of replacement fibrosis, and in some studies, connective tissue skeleton disarray. And of course, not just echo, but other imaging modalities can give us a window with respect to the subsequent or accompanying changes in cardiac structure, whether they be involving primarily remodeling only or modeling with hypertrophy, increase in LV mass that we quantify, as well as can grade on echo, as well as other imaging modalities. And changes in cardiac function are really being measured through a variety of different techniques now, the classic traditional ones that we're all very familiar with, and now more advanced measures and techniques that are being enabled not only through available in the lab, in clinical labs, available tools and techniques, but more advanced ones coming down the pike that involve artificial intelligence. Going back to echo and focusing on echo as a widely accessible imaging modality, this is one that's nice to use and nice for us to better understand in terms of its potential. Because it's so widely accessible, it's used in every clinical setting. It's now, of course, portable in its universality as a modality, and it continues to be used in research. So really giving us the ability to translate our findings from the bench to the bedside and back again. And so we're really focused still on echo in many respects for helping us to understand the progression from hypertension to end organ disease of the heart, because all the data continue to be collected in the real world as well as in research. And so when we talk about blood pressure effects on the measurable cardiac structural features that we capture by echo, it's helpful for us to turn to our classic model of left ventricular remodeling and then really lay out a possible pathway of progression. It's the classic pathway, but it's not always the same one for every patient. But we can at least use the framework of the paradigm to lay out a possible pathway of progression that involves each of the major left ventricular classic remodeling subtypes, especially if we want to consider the possibility of a patient who will then go on to develop what may now be considered the prototypical outcome of hypertensive heart disease, whether that be HFpEF or HFpEF actually transitioning to HFrEF or in some cases, patient progressing in a more accelerated fashion to HFrEF. So let's take a step back, take this case of a 47-year-old gentleman whose past medical history includes non-ischemic cardiomyopathy with a reduced ejection fraction of 15%, multiple episodes of congestive heart failure, lasting up to a year prior to the time of this echo that I'm going to show you, long-standing hypertension that has not been well controlled despite multiple medications, with blood pressure measures recorded as high as 210/110, morbid obesity, and obstructive sleep apnea. He's taking the medications listed here: furosemide, carvedilol, lisinopril, and spironolactone. Here is his echo from this clinic visit, and it shows multiple features of what could be attributed to long-standing hypertensive heart disease, assuming, of course, that alternate or additional etiologies were ruled out and not involved. And I can show you in this case, it's actually a former patient of mine, that was indeed the situation. All alternate etiologies were assessed for and ruled out. Here on this echo, we can see quite thickened left ventricular wall measures. We can also see on the apical four-chamber view very dilated LV cavity that could previously have been reduced in size, but is now the diameter it is shown here, and a clearly reduced fractional shortening, and in turn clearly reduced left ventricular ejection fraction. So this particular case is of a patient with volume overload in addition to a long-standing history of hypertension, all of this together indicating at least some substantial role for hypertensive heart disease. And this really highlights one end of the spectrum of possible progression. When we look across the spectrum, however, of all possible presentations, what about those patients who have not yet developed symptoms of overt hypertrophic remodeling? This is a nice study published recently by Mancusi and colleagues. And what they did was they took a closer look at individuals with hypertension that were considered or categorized as low risk. By low risk, they defined these individuals as lower risk based on not having any ECG evidence at all of hypertrophy. And they found that there can actually be LVH on echo, especially if there's the presence of other risk factors. You can see those other risk factors they studied here. They actually even came up with a nomogram. If the patient has older age, smoking history, current smoking history status, larger BMI, systolic and diastolic measures in the office at the time of the evaluation being on the higher side versus lower side, even some voltage criteria, Cornell criteria on the ECG, even if not meeting absolute criteria for hypertrophy, there being some millimeter criteria there, and then the presence or absence of chronic kidney disease. The more of these factors a patient had in the study, the more likely they were to have the prevalence of LV hypertrophy on echo, even if that criteria were not met based on ECG criteria. Again, sort of really emphasizing that it's not just the blood pressure alone or a single trait associated with elevated blood pressure. It's often a constellation of factors that deserve and warrant attention if we have a chance to consider them, that give us a signal that this person probably has something to find on the echo if we were to order the echo and make that assessment. So here's another study done in a large biracial population study of ambulatory elderly individuals. This is actually, again, from the ERIC study, the Atherosclerosis Risk and Community Study, where Santos and colleagues actually did a whole lot of measures for all study participants on the echo studies that were performed using a standard protocol. They confirmed the findings of prior studies. In particular, they identified key structural differences across individuals in the study who are categorized by their hypertension status. Here they use the more conventional, traditional definitions of hypertension status, where optimal was with systolic less than 120/80, pre-hypertension as shown here, with systolic in the 120 to 139 range and diastolic in the 80 to 89 range. What you can see here is they show that even those individuals with pre-hypertension had higher LV mass index, greater LV wall thickness, and measures that overall compared less favorably to those measured in the individuals with normal blood pressure. When looking at the presence of any abnormal LV geometry, again, Santos and colleagues found a higher prevalence even among those with pre-hypertension compared to normotensive individuals. So what we're really seeing here is a graded association, graded response. Not surprisingly, a lot of these same findings have been recapitulated when researchers using other types of study cohorts of different sizes, different age groups, different clinical and sociodemographic backgrounds have looked at blood pressure values across the full spectrum of numeric measures, and they found very similar results. So what's really important to note is that even at the earliest stage of hypertensive heart disease, whether we want to call it pre-hypertensive heart disease or something different or even earlier, the manifestations of LV hypertrophy and the other, I'll show you in the next several slides, and the other manifestations that have to do with cardiac structural but also functional sequelae of elevated blood pressure, they actually can be treated. So I'll start to show you some of these data now. In the classic seminal LIFE study that we all know achieved significant blood pressure lowering effects over many years, they did some of the earliest work looking at echo measures in conjunction with blood pressure lowering from deliberate treatment. Here are echo measures before and after, showing significant reductions in both relative wall thickness of the left ventricle and classic traditional measures of left ventricular mass. Those findings were from drug. These findings were mirrored in the much smaller, one of the earlier Simplicity study trials, where of course blood pressure was lowered not using drug specifically, but the intervention was renal denervation. And so really the point is, however you lower the blood pressure, whether it's through medication or it's through alternate intervention, if you can get the blood pressure lowered and controlled at a lower range, it will have effects on the cardiac manifestations. We also know from multiple studies that reducing LV hypertrophy substantially improves outcomes. It's really the reduction in the hypertrophy, even after you control for the relative benefit, so the outcomes-based benefit from the reduction of the blood pressure itself, and all of the other things that can be correlated with or associated with taking the medication or having the blood pressure reduced. It is this particular measure, the change in the degree of hypertrophy, that itself is also associated with an improvement in outcomes. So what about the individuals who are even earlier along the potential pathway to hypertensive heart disease progression? And these are the individuals who might actually have not recognized, remember earlier in our slides, we talked about those individuals who don't have recognized hypertension, or they have it and recognized but not controlled. But what if they don't even have it recognized because they're pre-hypertensive or intermittently hypertensive, or of course, there are variations that we haven't yet talked about, individuals with nocturnal or diurnal or white coat hypertension, all the different variations that don't yet clearly, overtly manifest as chronic, overtly elevated blood pressure. So it turns out when we take what we can of even the mildest affected individuals, we now know that LV function can actually be abnormal even when LV structure appears normal. So what we mean by that is in the setting of blood pressure elevation that may be subtle, that may be mild, that may be hard to detect, we can actually find, if we look hard enough, LV functional abnormalities that are present and measurable and significantly there and differential from normotensives. And they're there and they appear even before the LV structural abnormalities. What do we mean by these measures of LV function or cardiac function? They include, of course, conventional measures of diastolic function, which are now well established and recognized to be reduced in the setting of chronic hypertension. Here's a classic example on the right of somebody with reduced E prime, and on the left with somebody with normal E prime. One's lateral, one's medial, but you can tell that the reductions are still significant in the person on the right versus the person on the left. According, going back to some of the work by Santos et al. In the ERIC study, in their large population study, they actually found, in this particular case, no major difference in the crude measure of LV systolic function, that being left ventricular ejection fraction, across hypertension status groups. But they did find, as we would assume, as we've talked about, significant differences in measures of diastolic function. Again, even the pre-hypertensives had worsened measures of myocardial relaxation compared to normotensives. In fact, when you look hard at the data, over half of those individuals with pre-hypertension in this in the study using contemporary measures at the time, where pre-hypertension was really considered to be individuals who had blood pressure close to normal, almost normal, and in many clinical settings not considered worth treating. But over half of these individuals actually had measurable and significantly increased frequency of diastolic dysfunction. Why is this important? Well, we now know from multiple outcome studies that diastolic dysfunction is significantly associated with worse outcomes, including, and importantly, incidence of heart failure. Fortunately, diastolic dysfunction does improve with blood pressure lowering, as has been shown in several studies, including the VALID trial. The VALID trial used valsartan, the ARB, the angiotensin receptor blocker drug, as the primary intervention. But the same effects have also been shown. Again, this is data from the Simplicity trial that use renal sympathetic denervation. Again, however you get the blood pressure down, whether it's through a very good blood pressure lowering therapy, an oral medication, or through an alternate intervention such as renal sympathetic denervation, however you get the blood pressure down, the effects are favorable with respect to the cardiac manifestations. What we saw earlier was favorable effects with respect to cardiac structure, and here we're seeing, again, favorable effects with respect to cardiac function. One thing we have to remember when we're looking at all of these data is that changes in left ventricular cardiac structure and function from hypertension, so emanating from hypertension, can actually look very similar to the changes in cardiac structure and function that can be seen in aging. So how do we tease these things apart? So from population data, we see the same trends with aging as what we see with elevated blood pressure. So with aging, even after you control for as many concomitant risk factors as you can think of, you still see in women in the red lines and men in the blue lines very, very steady increases in these values that we know also are seen to be increased in the setting of elevated blood pressure. And these age-based trends are altered. In fact, some cases they're shifted. You see the difference between the bolded lines and the dashed lines. In some cases they're shifted or even attenuated in the presence of risk factors, including hypertension. So this is, again, you see these trends as a result of that chronologic, or you could argue the combined chronologic and biologic aging process, even after you account for presence versus absence of hypertension. The slope is altered with respect to the age-related changes, but they're still there. And so the question is, how might we actually differentiate effectively, satisfactorily, if we can, between the cardiac, especially the left ventricular changes that are really due to hypertension or elevations in blood pressure versus due to aging? And we want to reemphasize the point here that advancing age doesn't obligate elevations in blood pressure. Certainly from population studies, we've seen that there are people who are able to age relatively successfully from a cardiovascular standpoint where their blood pressure does not go up to the point where they become obligate hypertensive. So people who are fated to develop high blood pressure. There are many people who can age successfully and never develop high blood pressure. And yet they are still seen to have these changes in left ventricular cardiac structure and function. So how can we potentially tell the difference? Well, it turns out that the advanced echocardiographic techniques and methods that have been developed over the last several years can now allow us to get a little bit better, and in some cases a lot better, depending on which structure of the heart we're looking at. It allows us to get better at making more precise measures of left ventricular mechanical function that can help us tease apart the differences between what's happening as a result of aging, advancing age, or age-related elevation in blood pressure. In other words, the progression towards hypertension and, in turn, hypertensive heart disease. So these measures, strain or mechanical or tissue deformation of the heart, synchrony, the timing with which these mechanical changes take place over the cardiac cycle, and torsion, the relative difference between how mechanical function of the different segments of the heart are changing in relation to each other at the base versus the apex with every cardiac systole and diastole, every cardiac cycle. We can actually measure these things using echo. We're getting better and better based on the technologies improving each year. What are we doing when we're trying to make these measures based on echo and the sort of cartoon figures, the simplified schematic that I just showed you in the last slide? What we're trying to do is we're trying to take into account the subtle alterations that really are reflective of a much more complex, in real life, very sort of intricate network of myofiber, anatomy, and physiology. So here's really sort of a breakdown, a colorful schematic of how myofiber integrity and function are really aligned in the context of myofiber orientation. This is how we get not only circumferential, longitudinal, but that torsion orientation with respect to how mechanical deformation of the left ventricle, as well as the other chambers, the right ventricle, and so forth, are changing with every single cardiac cycle. Here's what it looks like when we start from the beginning, when we start from the acquirable, the accessible views from echo. So what you can see here is an example of speckle tracking myocardial deformation imaging that can be done in both the short axis that's shown up above, showing particularly short axis of the left ventricle measures, and also long axis views shown below. Apical four-chamber, classic speckle tracking tracing done on the left ventricle in the short, in the long axis as well as in the short axis. Here's an example of what you get from the long axis view. And what I'm going to show you next is how these measures, which we call strain measures, you get strain rate, and you also just get a strain, so strain rate being the change in strain over time. Even just strain, you don't have to even go so far as strain rate, although you get similar information. Global longitudinal strain here is shown from having been measured on a normally functioning heart with a normal left ventricular ejection fraction And the normal strain value, the global longitudinal strain value, as I've listed here, is in the normal range and negative 19%. These are values from a patient who also had echo done around the same time, where the LVF was actually also completely normal appearing. It was called within the normal range, between 55 and 65%. But the strain patterns, although apparently normal in terms of synchrony, the magnitude were actually less than normal. They were quite abnormal. And the global longitudinal strain, as you can see here, was actually very much in the abnormal range at negative 11%. And I'll tell you, the last patient was a patient who was not just normotensive, but had no heart failure. This is a patient who did have a history of hypertension and actually presented clinically with heart failure with preserved ejection fraction, given that a normal range LVEF. So beyond differentiating normal versus abnormal, we have seen from multiple studies now, this is actually one of the very first studies to show this very consistent result, that global longitudinal strain measures, here they use a cut point of worse than negative 12%, they are significantly associated with adverse outcomes. And this is one of the first studies to be published on the topic, and the outcome here was all-cause mortality. We and others have taken the same or similar approaches, where we've done the strain measures across large size cohorts of individuals living in the community, taken all the strain measures and looked at the degree to which they're associated with now specific outcomes, and not just all-cause mortality, which is the rightmost panel there, panel C, but also specific cardiovascular endpoints of importance. So panel A showing global longitudinal strain and its association with coronary heart disease outcomes. These are data from the Framing Heart study. And panel B showing global longitudinal strain measures and its association with incidence of heart failure. In the same population, we took the same or similar approach. This time, we looked at circumferential strain measures of the ventricle, very similar to what I showed you in some of the earlier slides from just a moment ago. Those same measures applied to this cohort from the Framing Heart study. And we found, in particular, that the circumferential strain measures were actually, it turns out, less specific for their association with coronary heart disease, but much more specific and very significantly associated with the incidence for heart failure. So here's now an example of where the different strain measures applied to views, echocardiographic standard views of the left ventricle, are helping us to tease apart relative differences in an individual's relative risk for one specific adverse cardiac event versus another. And it turns out when you really expand the database and follow up these individuals for longer, you do see that both global longitudinal strain as well as circumferential strain are associated with all-cause mortality, but that signal is much more significant for the longitudinal strain as opposed to for the circumferential strain, which seems, at least from our data, but also recapitulated by others, to be much, much more specific for heart failure. Here's a study done by Tor Bering Sorensen's group in Europe, showing additionally some new insights with respect to what global longitudinal strain in particular can tell us in the context of individuals with or without hypertension. And it turns out in this study, published also relatively recently, that global longitudinal strain, especially in these individuals without overt hypertension, is particularly associated with the incidence of ischemic heart disease or heart failure, even more so than in individuals with hypertension. In fact, in the individuals with hypertension, it's really not the global longitudinal strain so much as the overt difference in LV mass index that seems to be particularly predictive of whether or not among those individuals with hypertension, they go on to develop either ischemic heart disease or heart failure. So this helps us, I think, put together all the different types of measures that can be applied to the routine and standardly acquired echo views acquired during routine imaging, helping us to better differentiate not only what's going on with respect to our patients who might have early or even not yet identified hypertensive heart disease, and those who have later stages of hypertensive heart disease. So given that now numerous studies have shown us that elevated blood pressure is associated with worse strain, whether you make it into the hypertensive category, the pre-hypertensive category, or the pre-hypertensive category. When you look at strain and blood pressure measures together correlated on continuous measures. When you look at strain as a measure of mechanical function, the next question is, if it's abnormal in the setting of elevated blood pressure, the next question is, can lowering blood pressure actually improve strain and in turn potentially prevent some of the associated adverse outcomes? So these are data from the EXCEED trial. The EXCEED trial was a randomized trial of intensive versus standard blood pressure lowering using the same medications, but really targeting a more aggressive versus a less aggressive blood pressure target. So in the EXCEED trial, looking at aggressive, intensive versus standard blood pressure lowering and its effects on diastolic function. These are results out of the main trial. E prime, the pre-specified measure of diastolic function, significantly improved in both the intensive and the standard blood pressure lowering arms. So what we did is we took the same echoes where the E prime and the diastolic measures were done, and we went back and we took those historical echoes and we applied some of the same speckle tracking strain measures that we apply in the Framingham Heart Study, this time to the echoes from this clinical trial. And we also saw that global longitudinal strain was not only abnormal baseline, because of course all these individuals had uncontrolled hypertension and had abnormal diastolic function at baseline, but then at follow-up, after both groups had their blood pressure substantially lowered, either through intensive or standard blood pressure lowering regimens, we found that the global longitudinal strain also improved with blood pressuring in both arms. And so there's still ongoing effort to further research in all the areas I've just shown you. There are also areas of ongoing discovery and therapeutics in the field. They're probably beyond the scope of this talk that are ongoing, but some work. This is one area of some work that is well in gear, well underway. Some of this work is being done to move beyond the classic LV remodeling scheme. It's still a classic theme, still incredibly helpful for thinking about patients as well as research populations. But if we wanted to try to move beyond the classic LV remodeling scheme, we're actually trying to focus on capturing blood pressure-related changes at the microstructural level, not just the macrostructural level, and potentially putting the two together to try to understand what is happening. We'll go back to earlier in the talk at the cellular and tissue level, in addition to the gross structural morphologic level that we know we can more easily identify through echo. Now through AI technologies, we can actually try to get at more of the microstructural alterations, even without having to do that much more to alter the way that we acquire our echo images. But it's really a matter now of trying to put the whole picture together in terms of potential information intake and processing from even just the standard echo. Additionally, some intriguing work is also still being done in the area of using deformational measures to capture segmental dyssynchrony. I mentioned before that when you look at strain, you can also look not just at the magnitude of the differential strain measures in anybody with any type of heart disease, including hypertensive heart disease at its various stages, but you can look at the timing or the time to peak strain or strain rate measure across various segments of a left ventricle screen capture or cine set of images, whether they're captured in the 4-chamber, 3-chamber, 2-chamber, or short axis views. You could look at the timing and try to understand these in relation to hypertensive heart disease. And it turns out, we and others have shown that the left ventricle is actually measurably and significantly desynchronous compared to the left ventricle of a heart of somebody who has not yet had their blood pressure elevated. So the left ventricle of a heart in somebody with long-standing hypertension without any other cardiac comorbidity or any other cardiac diagnosis is usually more desynchronous than that of somebody with a normal blood pressure. We've seen that not only in humans and patients in the clinic, but also we see this from mouse models. This is actually a slide from a mouse model of hypertension. And we see evidence for why it is that hypertensive heart disease would result in desynchrony. And it turns out it's because from a mouse model, as well as from humans whom we encounter in the clinic, chronic afterload stress actually appears to affect the myocardium in much more of a heterogeneous rather than homogeneous fashion than we previously appreciated. You can see here that the fibrotic changes, interstitial and replacement fibrotic changes, are actually present in more of a patchy distribution rather than in a uniform distribution across the entire left ventricle. And this is just in the setting of a hypertensive stress, an afterload stress, not in the setting of any other type of stress, such as a regional ischemic stress or anything quite like that. So in summary, we can take away a few key points from what we know so far from our clinical experience as well as from research. And that is that, first of all, of course, hypertension is a widely prevalent problem, especially in our continuingly aging, expansive population, undergoing and experiencing all different types of stressors that would cause the blood pressure to be elevated and stay elevated. Echocardiographic assessments of cardiac left ventricular structure and function can identify among the earliest signs of end organ damage from hypertension. These include concentric remodeling, concentric and eccentric hypertrophy, and beyond. They also include diastolic dysfunction, as well as abnormal longitudinal strain, and these are even beyond or even before advancement and progression towards the more overt forms of cardiac dysfunction. Fortunately, we've seen from the data I showed you, as well as other studies, that antihypertensive therapy can improve both cardiac LV structure and function in the setting of hypertension. And fortunately, as we've seen from prior studies and what I'm sure we will see from current ongoing and future studies, improvements in LV structure and function, however we measure them, will continue to lead to better outcomes if we can just get that blood pressure lowered. However, the intervention we apply is applied. However, we can get that blood pressure lower in the setting of even the earliest forms, and even in the, I should say, even the more advanced forms of hypertensive heart disease, we can see improvements, and those improvements that are measurable in the imaging, we have seen are associated with better outcomes. And more data, we are confident will emerge to prove this is the case. Let's go back to an individual patient example of this. Here's a return to our 47-year-old gentleman with a past medical history of non-ischemic cardiomyopathy that originally reduced EF of 15%. All those episodes of symptomatic heart failure requiring hospitalization and clinic visits, and that very sort of profound, long-standing history of uncontrolled hypertension with episodes actually even of hypertensive urgency and emergency. So what happened to this particular patient? With a lot of extra help, medications primarily to try to get the blood pressure under control, particularly to try to get it under the 140/90 at that time. That was the standard goal. But even further, sort of aggressive and intensive thresholds were targeted over the course of many clinic visits. What happened subsequently? Well, just within a year, actually, it turns out, of that original echo I showed you earlier. Here's a follow-up echo. As you can see from the follow-up echo, the left ventricular walls are still very, very thick, but the ejection fraction is remarkably improved. Not back to normal, not completely back to normal, but definitely not in the 15% range as it was before. And you see that not only in the parasternal long axis view, you also see that here in the apical four-chamber view. Again, the EF is not completely back to normal, and if we'd applied strain measures, we'd see the strain measures are not completely back to normal, but the improvement is definitely there. And so the ultimate take-home message would be that for hypertensive heart disease, medications work. Earlier is better than later, but it's never too late to try. Thank you very much for your attention.